I believe we can absolutely measure our clinical outcomes, and we can absolutely impact the diagnosis and treatment of patients in our hospital, and we can absolutely improve the clinical outcomes of our patients over time. There is tremendous variation right now in the practice of medicine, no matter where you go. So we want to do the right thing, but we don't want to do more than the right thing. We want to do only what you need to effectively treat simple pneumonia and send you home, because every time we do something, there's a complication rate. Some of those complications are very significant, and they can result in very unfortunate outcomes or consequences. You can end up in a longer stay. You can end up in a critical care unit. There are things that happen. So we want to make sure that only the right thing gets done. We want to make sure that there's as much predictability in the process as possible. Performance improvement to me is a common operating methodology, almost a universal interpreter, if you will, that you can put in place in an organization, and you can have physicians, operations folks, caregivers, board members. You can have everybody conversant on the same methodology of looking at how we advance things ahead. Performance improvement is an operating methodology, if you will. It's the scientific method of improving services, operations, virtually everything we do in the organization. It's not cookbook medicine. It is reducing the variation in what happens to the patients. If you relentlessly focus on improving your clinical outcomes, your finances will improve over time. My feeling is if you focus on your financial outcomes and don't change your clinical outcomes, then it doesn't work. We're not a business. We function and focus on business principles, try and run as efficiently and effectively as we can. But we're a charitable organization. We exist for the betterment of the community that we serve.
Not too long ago, 2 years ago, you guys had a pretty dismal rate on the surgical care improvement plan. 16% defect-free?
Correct. We have improved our processes, to be sure, but what I'm saying is that some of the extremely poor numbers weren't strictly a failure to do the right things clinically, but we have to perform according to very strict rules of what we have to consider as a positive or a negative. So the numbers are more.
As a consumer, I'm looking at that Q1 score, right, and saying,
correct.
You know, I'm not sure.
You don't know that this is simply documentation. I agree with you. This was a wake-up call that we were not going to be satisfied to say, we know we're better than that. It's that 2-minute rule that killed us. We said we have to make sure our processes are so reliable that we won't have to worry about the 2-minute rule, because we will have the outcomes that we can hold up against anybody, and we have.
We are not graduating enough primary care physicians in Massachusetts. We can, look at physician recruitment and the difficulties we have getting practitioners to move to Massachusetts. Mm-hmm. Researchers, teachers, not a problem. But look at the graduation rates from the fellowship programs, the residency programs in Massachusetts. Look at the specialties, and you tell me where those folks go. You tell me how many primary care practitioners stay and practice medicine in Massachusetts. I think you'd be shocked at how low that number is.